Dissociative disorders. This is still a very controversial area, but just for a minute, think about what Aaron just left off with. First of all, you picking me up now up there? Everybody can hear me okay? Still can't. Okay. All right. Well, I made sure it wasn't on mute.
If you want, you could go in the middle and talk there, and I'll move the slides for you.
No, I like this. What'd you say?
The mic only works for the video recording.
Oh, all right. I got you. Thank you. Superstitious learning. Okay, thanks. All right, I'm going to try to talk in my Brooklyn ways. But notice where this disorder is coming in, right after what Aaron talked about, all the trauma. So, and it makes a lot of sense because the research shows that a lot of trauma can develop into dissociative disorders. And those who remember what that is, those are people or individuals who disassociate from themselves or from the environment. It's really a nice way of having arranged that. What's changed is depersonalization and derealization disorder is now one where a person can feel that they don't belong to themselves, they don't feel attached to who they are, versus derealization where and I think a lot of us probably have experienced this, where you're in a certain situation like you can't believe, you don't feel like you're part of the event or reality. It's missing, almost like a fugue state and that kind of thing. Talk about fugue, dissociative fugue. It's now a specifier. Those of you remember dissociative fugue, those are the conditions where supposedly somebody would wander away and have no idea where they are, how they got there. Sometimes they don't even know who they are as well. But now that's a separate disorder. That happens so rare that the research said it happens, but it's part of another disorder. The dissociative disorders is also now to include, and this kind of gets a little funky. Remember what Aaron was talking about, cultural phenomena, trying to differentiate what's cultural and what's a disorder. But possession form phenomena, argue with it or not, the data is suggesting that there is a dissociative identity with believing that you're another possession or being possessed as well. There's also a marked, I guess, emphasis on that if you don't see the dissociativeness in you, others may. So people scratch their head and say, is this the same person that I was just dealing with? It seems so different. What was it? Me, Irene, and I, like that. Myself, very like that. Although they call that schizophrenia there, but it was dissociative, right? And doing that, that's just the comical one of it. And sometimes they didn't even know he was transitioning until people brought it to their attention. There used to be old movies about this with multiple personality disorders, and there was a big controversy. 3 Faces of Eve. Have anybody ever seen that years ago? You're right. So that's there, and it's still controversial whether or not that is a legitimate disorder, but it's still in the DSM-5, so we're going to have to learn it. Now I want to get into somatic symptoms and related disorder. This has undergone a significant change. It used to, in the old DSM-4, it was the somatization disorder, undifferentiated, this differentiated, that differentiated, pain disorder, this disorder, that, all under somatic, hiccup disorder. That's gone. It's very nicely cleaned up, and it's merged into somatic symptom disorder. Aaron talked about the mind-body dualism, which, by the way, started way back with Rene Descartes, where a good way to look at this disorder is how well are people adjusting to their diagnosis, to any medical condition, minor or whatnot. And how do they deal with it? How are they adjusting to it? And that's where this has really revolutionized how we look at somatic disorders. And again, it's on the spectrum. What has been eliminated is hypochondriasis. Again, that comes under somatic disorder. Hypochondriasis are people who think they have every disease that ever comes out. There's a new disease of the month, they got it. Or they're doing things to prevent it. And I have some real situations where people were buying all kinds of supplements and vitamins and herbs and going to all these different kinds of doctors thinking that they're going to have to cure themselves of some perceived disorder and doing that. What's new is illness anxiety disorder, and we're going to talk about that in a little bit, but hypochondriasis now fits a lot of those individuals who used to be diagnosed with that will now fall under illness anxiety disorder. Pain disorder. There's a less emphasis on separating it from the medical. There can be some pain, but again, it's how you are dealing with it and your reaction to it and to what extreme. And again, this just goes over the symptoms, and the symptom severity depends on the number of symptoms you meet under a somatic form disorder, and I won't take up much time with that. You can specify with predominant pain, and it has to be persistent as well. Illness anxiety disorder. This is the new one. I call this the Woody Allen disorder. I don't know if you know Woody Allen. He was always worried about some very anxious individual. Either something was going to happen, about to happen, could happen, and sometimes when it did happen, it was way out of control for what the real crisis was. But again, it's a preoccupation with acquiring a serious illness. And you do things either to prevent it or to treat it, and you go overboard. And it is very alarming because you're very anxious about it. Interesting, there are two types, and this was kind of made sense when I started thinking about it. You can specify whether there's care-seeking types. So care-seeking type is the one that actually frequents the doctors often, buying all kinds of remedies to either prevent or to cure, which obviously is way beyond what's needed, or care avoidant type. So these are people who are so anxious about getting sick that they deny that anything is wrong at all and refuse all care, and anything that has to do with reminding them of that, it's almost like a PTSD reaction. And again, that's why it falls right after that. They avoid anything that has anything to do with it, which can be problematic because, again, under somatic disorder, there can be something medical that probably may need attention, but to avoid it it can create a serious problem and exacerbate the medical condition.
Or do you think there could be any comorbidity
with agoraphobia?
Yeah, like if they are afraid to leave their house, interact with other people, is there...
It's really more specific to avoiding stimuli that has to do with the illness.
Okay,
right.
So doctors and
yes. Or even TV shows that may have it,
right.
That kind of thing. This is just so, conversion disorder is still there and it's still defined as such. And all the specifiers with it, the speech symptoms, dysphonia, slurred speech, attacks of seizures, and that's all. And again, or dystonic, actually I had somebody like that. Again, the reason why I put this in here, not that so much it's new, is that again, it's relevant because they're tying in some possible medical condition and that it doesn't, and that it isn't a separate entity without the biological component, and this really hits home with that. This particular area is kind of related to the illness avoidance. is psychological factors affecting other medical conditions. These are the people, and I'm sure we all deal with it, and very frustrating, where they have a medical condition, they just suffered a heart attack, and they're still smoking. Or they're diabetic, and they're still eating lots of sugar or carbs and expanding their weight. Or they take health risks for whatever reasons. And this is mild, moderate, severe, and extreme forms of that, doing that. Factitious disorder still finds its way. It used to be Munchausen syndrome, Munchausen by proxy. Remember, factitious disorders is imposed and there's no obvious external reward. And now it's called factitious disorder imposed on another. Many of you who've worked in hospitals have probably seen a caregiver bringing a kid in, saying that the kid has all these significant medical conditions and they need to be treated, or you may see kids who are being over-treated for what's common ailments, and the caregiver insists that this kid is sicker than he is. And oftentimes these caregivers get reported for child abuse as well in doing that. All right, feeding and eating disorders. One of the new areas that has been recruited from the DSM-5, which now includes adults, are avoidant restrictive intake. Those that is a feeding disorder that has to do more with either someone not liking particular texture or smell. So, for example, somebody avoids, let's say, all vegetables, raw vegetables, because of the way the texture is, and they'll avoid that. And it can be obviously clinically significant, because if you avoid too many vegetables or don't get whatever vegetables provide, you can get some type of nutritional illness in doing that. So that now includes the lifespan. Anorexia nervosa, excuse me, and bulimia, minor changes. The way it's measured has been nice. There's a better insistence on using the BMI, the body mass index. So, for example, 17 and low is considered, that's pretty low body mass index as anorexia. Also, the criteria for diagnosing or the frequency has been lessened. In other words, the frequency occurs once a week, and for let's say bulimia or even binge eating can be considered part of the diagnosed criteria. The new disorder under feeding and eating is binge eating disorder. In essence, it's bulimia without the inappropriate way of getting rid of the food and doing that. And again, it only has to happen once a week. I call this, especially now that the holidays are over, the holiday disorder.
Yeah.
And pretty much the way it is, it's eating so much food, and they say in a 2-hour period of time. And if you were at my house, we go 4 hours, and we just nonstop, and you can cut it off at 2 hours, and it'll look just like it did at the end of 4 hours. It's pretty fun. All right, never. So it's also a sense of lack of control. They can't stop. They overgorge themselves, so they're so uncomfortably on food. But however, there may be some mechanism where whatever controls satiation is not quite working. It's an interesting, I was just reading that in the hypothalamus area of the brain and doing that. Okay. So again, it has to, and I guess this is what separates out binge eating from holiday binge eating, is that there's marked distress, and of course you do it a little bit more frequently than after the holidays as well. Of course, after you eat so much, you want to sleep, and that's what brings us right into the sleep-wake disorders and doing that. We've done a much better job over the years of recognizing the medical components that drive sleep-wake cycle. In fact, a friend of mine, he just passed away, Dr. Wes Wesley, one of the pioneers in sleep research from the University of Florida. Florida was one of these who did a lot of work on REM sleep and doing that. But the breathing-related sleep disorders now are divided into 3 groups. There's obstructive sleep apnea. That's where there's an actual blockage of the airways, and that requires a surgical intervention. Then there's the central sleep apnea. That has to do with the hormones or the neurobiological basis of sleep in the brain. And of course that can be controlled with some medications. Sometimes it may require surgery as well. And the last one that you probably are most familiar with is the sleep-related hypoventilation. And that is the one that has the CPAP machine. There's a correlation with obesity with that as well. So again, you probably need a good differential diagnosis and obviously medical attention to figure out which one of these an individual may have. Of course, the side effect of any of these is lethargy, depression, moodiness, etc. So you have to, again, be careful as to what the etiology is of that presentation, and again, a good differential diagnosis is needed. Circadian rhythm, sleep-wake disorders, that has been expanded to several different subtypes. The NOS category, as Aaron brought up, has been reduced. There used to be the REM sleep and non-REM sleep now is part of the DSM-5 picture. The non-REM sleep is the ones that probably you're more familiar with. Those are the ones with the somnias, where somnolence, sleepwalking, people in a half days, getting up in the middle of the night, walking, doing something, and going back to bed. Usually that's pretty harmless in doing that. And rarely do they ever remember doing it. The other one is REM, rapid eye movement sleep behavior disorder. That's the one where people have vivid memories of what they've done, but it's uncontrollable, and they may strike out at somebody, do something, they fear that being attacked. And if you had nightmares where you really felt you were really in that situation and you acted on it, and obviously you remember it. And that can cause some interesting situations. This particular disorder has been used in defense, where a husband or a wife has killed the other one, claiming to have been in that state, and it had been used successfully. I wouldn't recommend it as a defense unless you can demonstrate a long history of it and being treated for it, but that is the one that's been used in defense. Obviously very important. Sexual dysfunctions. The two, actually they've done a better job with this. Dyspareunia and vaginismus is now into genitopelvic pain penetration disorder, and the subtypes are gone. It's either you're having difficulty with intercourse for one reason or another, and creates obviously significant problems, in particular probably in relationships. Gender dysphoria. I'm not even sure this even needs to be in the DSM-5. It's my bias, just like homosexuality used to be in the DSM, you know, all the way up to the 4. This is a one where, and they're doing a better job, but I have to admit that. It's a dysphoria, meaning that the individual, and there's a different criteria for children versus adult, is distressed over their sexual, what they are assigned sexually, and what they believe or perceive that they would like to be. So it's a conflict. And it doesn't matter if it's male wishing female or female wishing male. That's irrelevant. The point is, it's that it creates undue distress. My point is, in developmentally, when you're growing up, sexual development is distressing especially if you're trying to act socially upon, develop sexual interests as you get older. And this could be just one of them. And why it's pointed out, I'm not really sure. But anyway, for right now, that's what has changed in that. Again, what's also changed is the subtyping is irrelevant. It's replaced by the strong desire to be of the other gender. And it's a little bit more sensitive. And we talked about why the name change as well. But let me just quickly go through the differences between the child criteria and the adult. With children, you may see things, for example, boys, and I say that, who want to shy away from any typically masculine types of activities. They're a little bit more, sometimes you'll see them more sensitive, more involved in activities that usually involve play, that typically have been female-oriented, who want to wear female garments, for example, or playing with dolls, etc. And it creates stress when you take it from them. If they have a preference, they go to that as well. With adults, you do have the lack of congruence between the assigned sex and what it is they're desired to be in doing that. And it has to be of significant duration, at least 6 months or more. Any question on that one? That one, okay, good. We'll do that. All right, now we're getting into the next area of the DSM-5 called externalizing behaviors. Prior to this, everything we were talking about were internalizing behaviors, or internalizing psychological process. The depression, bipolar, schizophrenia, that's internal conflicts. These external behaviors are behaviors or diagnoses that has to do with individuals acting upon someone else or on the environment. Yes?
Yeah. So the TA may help me but have I missed Paraphilic Disorder? Yeah, have you done that?
Which one?
I'm sorry, I didn't catch you.
Have I missed Paraphilia?
Paraphilias? Yeah, we're coming to that.
Okay. All right, cool.
Yes. Okay, that had, you're right. You're right. Why it's like that, I don't know. I'm just going with the flow. I just drive the bus. They didn't ask me to put this together. Right. But you're right. And just to piggyback on what you said, the same thinking applies to paraphilias as it does to gender dysphoria. It ain't a disorder until it becomes a problem.
Yeah.
But we'll talk more about that as we go along. Do that. All right, externalizing behaviors. That's an interesting dichotomy, internalizing, externalizing behaviors. There's a psychiatrist, and this was almost adapted into the DSM-5, McHugh. His taxonomy has 4 areas that you could break down the DSM-5 into. And one could be behavior disorders you're born with, disorders that are acquired, disorders you do to others, and the disorders you feel internally. That's kind of interesting. I kind of like that. You can do that. But anyway, these are the externalizing ones. The first one you have is oppositional defiant disorders, and they've now put it into 3 types: angry, irritable mood, argumentative, defiant, vindictiveness. At one time, if you were oppositional defiant, or ODD, odd people, okay, that excluded you from the other subgroup of being conduct disorder. Well, the research says it is too tough to differentiate that out. A lot of kids who are conduct disorder started out oppositional. And you don't have to be a brain, some scientists go, yeah, probably the kid who's acting out and being vengeful and deceitful and planning those things is well on the track to being conduct disorder. So anyway, it's not exclusive in doing that. The severity rating has added into mild, moderate, and severe, again, depending on the number of symptoms you meet. Conduct disorder. What's changed there is the prognosis state of someone with a conduct disorder, and that's with limited prosocial emotions. So, one of the classic hallmarks of somebody with a conduct disorder is doing things and not caring about it. You know, killing animals, purposely starting fire, cheating on tests, stealing, and their conscience is next sentence like, oh well, taking, using a gun and a PB gun, shoot at someone's eye, and the response would be, and this is true, I'm not making it, says, well, he has another eye. Yeah, that kind of an individual. Prosocial emotions has to do with the degree of the individual has empathy or remorse for what they've done. Obviously, those who are less remorseful, less empathy, the prognosis of them not developing or obviously doing more or being cured or finding themselves incarcerated is much better prognosis with those who have more prosocial emotions. I don't know if you can see that, and I wanted to mention this before. Antisocial personality disorder is mentioned under this. Those of you who work in the criminal system, you will see that diagnosis a lot. That is what the lifespan looks like. What happens when individuals go through these particular disorders, it could really be an antisocial personality disorder. I failed to mention when we talked about schizophrenia, schizotypal is another personality disorder that is mentioned under schizophrenia. And the reason why I bring it up is because, again, the thinking behind the DSM-5, it's a dimensional, and wherever possible, they're also showing you not only comorbidity, prognosis, but what is this thing going to look like when you go through the lifespan? And that's why I put that in there, to just give you another example in doing that. Intermittent explosive disorder, we kind of talked about. Again, that is the individual who reacts so terribly to the minimal amount of discordance with what they see as a discordance in things happening to them. So, for example, if you give a mild criticism, for example, if you say, why don't you go ahead, you didn't fold your nice clean shirt, it's going to get wrinkled, and the kid starts cursing you out or becomes physically aggressive. Under the DSM-4, it had to have been a physical manifestation of that. On the DSM-5, it could be verbal threats is now part of the criteria, and that's changed as well in doing that. All right, with that, I want to just quickly, I guess we're going to be ready for a break.
Yeah, what we're going to do is take just a 10-minute break, and then we'll move on to substance-related disorders.
Who you absolutely have here probably the most knowledgeable in the state of Florida regarding substance abuse.
And so in the future, we might be seeing some other new additions outside of the realm of substance use that come into this chapter that are addictive processes. Basically, when it comes down to it, any behavior that activates reward circuitry in the brain is potentially addictive. And so we may see a lot of revisions coming down the road here. But for now, we've got gambling disorder in there. This is the biggest change probably with substance use disorders, is that in the DSM-4 we used to have substance abuse and then we had substance dependence. There were essentially the biggest difference between the two was severity. Substance abuse, when you look at the criteria, was basically a less severe version of dependence. So again, keeping in with their focus on taking similar disorders, merging them together, but then creating a range in terms of severity, they took abuse and dependence, collapsed them into one disorder, and it now ranges from mild to severe, depending on the number of symptoms present in a given 12-month period for the person. So there are some benefits and drawbacks to this approach. One of the benefits, well, I'll get to that benefit in a second because it's hard to see on this slide, but there are, if the person has 2 or 3 symptoms, then it's a mild disorder. 4 to 5 is moderate, and 6 or more is severe. They took away the criterion about recurrent legal problems. There used to be, under abuse, recurrent substance-related legal problems was a diagnosis, was a symptom. There were a few problems with this, and one problem could be that one thing they paid attention to is they were trying to be very culturally sensitive. And they found that there are some minority groups that if they're engaging in the same behavior as, say, a white male is, they're statistically significantly more likely to be arrested for it. And even though the behavior may be identical between the two, because of that sort of cultural bias, one's going to be more likely to meet the symptom than the other one will. So that didn't make sense. That's one reason they got rid of that one. The second one is that anybody they found who met that criteria of recurrent related legal problems also met some of the other symptoms on the list. So by itself, it served no predictive validity. So that's another reason they got rid of it. They added craving, a strong desire or urge to use the substance. Go figure, that was never part of the diagnostic criteria until now. Kind of makes sense. So they also increased the number of symptoms one would have to have in order to be diagnosed with a substance use disorder. It used to be one symptom was sufficient for a diagnosis of abuse. But now you must have at least 2 symptoms. And part of that is because there were some scenarios where it seemed like somebody would meet the just minimally one symptom and is that really a disorder or not? They wanted to strengthen the sort of validity of the concept of a substance use disorder. So that's why they did it, for better or for worse. Now, one of the drawbacks to removing that legal criteria is that this may come as a surprise to you, but oftentimes individuals are not forthcoming about their substance-related activity when they're being evaluated. In fact, the vast majority of people who see a practitioner for a substance-related problem are mandated, coerced, or forced in some way to come. So they tend to not be forthcoming, and even if they were being forthcoming, aren't always fully insightful about the connection between their behavior and their consequences. So for those of us who are evaluators, that recurrent substance-related legal problems criteria came in very handy, because they could deny everything down the list, but then you pull the record and you see, okay, we got 2 DUIs, we got a couple possession charges, we got disorderly intoxication, and you got enough for a diagnosis, regardless of what they're reporting in that kind of a scenario. So, there are benefits and drawbacks, again, to what they've done there. I understand it, again, the DSM-5 wasn't written for forensic purposes, but it has forensic implications because people use it for forensic purposes. Okay, so they also added 2 new diagnoses. Cannabis withdrawal is one, and caffeine withdrawal is another. We all know about caffeine withdrawal because everybody in here is a current grad student or a former grad student. So we'll talk a little bit more about those 2 in a moment. There used to be, under the old system, no such thing as nicotine abuse. It was dependence or nothing. It was an exception because if you had alcohol, for example, you could have abuse or dependence. And that problem no longer exists because if you're squishing the 2 disorders together, you can have, they now call it a tobacco use disorder instead of a nicotine use disorder, but you can have a mild tobacco use disorder. And I've already seen in many evaluations that I've done, a lot of people have a mild to moderate tobacco use disorder that maybe wouldn't have met the criteria for nicotine dependence in the past. But they still have some symptoms. So let's look at the specific diagnostic criteria for cannabis withdrawal. This one is, basically we're talking about a long-term chronic user, probably daily or almost daily. They stop using, and what they'll tend to experience is irritability, anxiety, depression. They're going to maybe have some appetite suppression. Sleep is going to get off. Oftentimes some insomnia. Oftentimes they report strange, vivid dreams, sometimes very disturbing and troubling dreams. It's partly because THC binds to a receptor, one of the common parts of the brain with a large number of cannabis receptor sites, is the hypothalamus, a regulation center of the brain. And one of the things it regulates is sleep, also regulates hunger. It's involved in that process, so the munchies. With sleep, though, it decreases the amount of time that people spend in slow wave sleep and REM sleep. which means, and that's where the bulk of your dreams happen, especially vivid dreams and REM. So if you're not getting good slow wave sleep and REM sleep because you're a chronic marijuana user, you're not having a lot of vivid dreams. They stop using and suddenly the vivid dreams start coming in, and it can be sort of disturbing for a while. So these are some of the symptoms that you'll see. This I'm glad they did because the clinical evidence of a cannabis withdrawal has existed for a very long time now, and they're now finally implementing it. There's this common myth out there that marijuana is not addictive, or a similar myth is, well, it's psychologically addictive, but not physically, mind-body dualism. But even under the DSM-4, with physiological dependence, tolerance, and withdrawal, there were people, chronic long-term users, who had tolerance. It takes more to get the same feeling I used to get from less. I need higher quality weed. I need a better strain of weed. I need more to get the same feeling. That's tolerance. Second is withdrawal. And there's been a clear cannabis withdrawal that many people experience. Now, we're talking about a small percentage of people who have used marijuana here, but still. So they've added that. So then we get to caffeine withdrawal. You kind of know what that is, right? You know, headaches, fatigue, drowsiness, dysphoric mood, depressed mood, irritability, difficulty concentrating, and in some cases, flu-like symptoms. So this is another change. We used to say that somebody was in remission if they had had at least 30 days of the absence of symptoms. A lot of people think it's at least 30 days of not using the substance. That's not true. It's the symptoms. Technically, somebody could still be using but not having any of the symptoms. It's probably rare once they've had a use disorder, but it's how long has it been since they've experienced any of the symptoms? And that period of time to be considered in remission has increased to 3 months, or about 90 days. They have to have an absence of symptoms for at least 3 months now to be considered in early remission. Sustained remission is 12 months or greater. That's the same as it was with the DSM-4. Why is that? Well, because the research pretty clearly demonstrates that 30 days in of no symptoms, people are still having a hard time adjusting. Relapse rates are still pretty high, and really to be considered in remission, for them to be sort of stabilizing and their brain to be adjusting, we're looking more at like about 90 days. That's why you'll see that the recommended minimum period of treatment for substance use disorders is about 3 months. Because that's just enough to try and get people to a state where they're sort of in remission, right? So they used to have a specifier with or without physiological dependence. If the person had tolerance or withdrawal, you would say with physiological dependence. They got rid of that specifier. Why? Can you guess? Mind-body dualism, right? There's a physical dependence and a psychological dependence, and the two are somehow magically distinct different things. So they said that doesn't make sense. And the verbiage dependence by itself was very conflicting, because some people, when people hear dependence, they think of tolerance and withdrawal, or hopefully they think of that. But a lot of people had a substance use disorder who didn't have that, and yet the diagnosis could still be dependence under the old system. So it's very confusing, all this terminology. So again, now it's a use disorder ranging from mild to severe. No specifier for with or without physiological dependence, because it really doesn't matter, because the mind is part of the body. It's kind of the idea behind it anyway. So if we kind of do a comparison here, again, we got the DSM-4 side by side with the DSM-5 criteria here. We squish the two together. We get rid of the legal requirement, or the legal symptom. We add craving. And we say you got to have at least 2 of these, whereas with abuse, you used to only need 1 symptom or more. So here highlights another benefit of this change. We used to have, under the DSM-4, what was called diagnostic orphans. Diagnostic orphans would be people who met, say, for example, 1 or 2 symptoms of dependence, right? So if you don't have 3 symptoms of dependence, you get no dependence diagnosis. Had to be at least 3. So they might have 2 symptoms of dependence. But then we go here, and we have evidence of 0 symptoms. We don't have any evidence that they meet any of the symptoms of abuse. So what do they get? No diagnosis. Diagnostic orphan, even though they have 2 symptoms. Meanwhile, somebody else has 1 symptom of abuse and they get a diagnosis. But they may have a less severe presentation than the person who's got 2 symptoms and skates under the diagnostic radar. So the diagnostic orphan problem is eliminated with the 2 disorders being merged into one with a spectrum of severity. Does that make sense? Okay. So they also reordered the 11 symptoms. They ordered them because they wanted to clump these symptoms together into some concepts. The first 4 symptoms are about impaired control. Symptoms 5 through 7 are about social impairment, the person's ability to function in the context of a society, relationships, and those sorts of things. The next set, symptoms 8 and 9, are about risky use, physically hazardous situations, being impaired, driving under the influence, things like that. And by the way, this is another illustration of why the legal symptom, didn't have a lot of predictive sort of validity by itself. If, for example, you've got 2 DUIs, then you've probably got recurrent use in physically hazardous situations, driving under the influence, right? If you've got disorderly intoxication charges or domestic battery charges that are alcohol related, you've got recurrent social or interpersonal problems caused or exacerbated by the effects of the substance. So you've got other symptoms going on, even if you're not acknowledging it, if you've got those arrests, chances are. So you can still use those arrests as a guide for, okay, could these symptoms be applicable in the person's situation? And then the final 2 symptoms, tolerance and withdrawal, that we used to call physiological dependence, we now call them pharmacological criteria. This is something some people do not like. If the person's being legally prescribed a medication and they're taking it as prescribed, you cannot count those 2 symptoms for the diagnosis, because they can be expected to have tolerance or withdrawal. But if they're legally taking it within prescribed parameters and none of this other stuff is going on, then those 2 symptoms don't count. And some people say, well, that's kind of makes sense, because you could be dependent on a substance, but not taking that substance would actually create far worse problems for you in the case of some people, say an insulin-dependent diabetic, for example, So they say it makes sense in that sense, but the drawback is, what about people who are being prescribed ungodly large quantities of opiates or benzodiazepines? It's clearly causing lots of dysfunction in their lives. Can they be diagnosed? And so that's the controversy there. Here's another problem that merging the 2 disorders together causes. Again, the DSM-5 is not written for government programs to have a way to use eligibility for their social programs and things. But that's a natural implication for any revision to the DSM-5. You look at the ADA, for example, the Americans with Disabilities Act. A drug addict is protected as long as they're not still using. It's a protected disability. Therefore, disability programs can make people eligible for services in some cases based on a chemical dependency, whether it's alcohol dependence or it's cocaine dependence or opioid dependence or whatever. For example, vocational rehabilitation can make people eligible for a chemical dependency if they're not currently using. Traditionally, abuse diagnoses were not considered for eligibility purposes because abuse was considered not a permanent disorder, not necessarily a disability, and they had to be dependent because of the verbiage dependency or dependence with the legislation. But now that we got rid of that verbiage, and it's a use disorder ranging from mild to severe, where will we consider somebody to reach that threshold of dependency? Well, I think what needs to happen is legislators need to catch up with the clinical world, not vice versa. We don't need to model what we do to fit into what legislators are doing. It needs to be the other way around. So they probably need to go back to their verbiage and look at maybe making some changes to the legislation and to these government programs. Maybe they want to say, for example, it's got to be a moderate to severe substance use disorder to be considered for eligibility purposes. That would make sense to me, because when you look at the ICD-9 codes in the DSM-4 for alcohol abuse and alcohol dependence, you see 305.00 for abuse, 303.90 for dependence. When you look at the ICD-9 codes for the new DSM-5 alcohol use disorder, mild is 305.00, what used to be abuse, and dependence is moderate to severe, 303.90. So there's sort of an inference that maybe we can conceptualize a moderate to severe substance use disorder to be what we used to call dependence, and a mild substance use disorder to be what we used to call abuse. And maybe that would be a good guideline for government programs to go by. But in the meantime, I think there's going to be a lot of confusion in a lot of these programs when it comes to eligibility determination. We got any VR counselors in the room, by the way? One. Okay. Two. And then there were a few who didn't want to raise their hands. Okay. All right, so I am now going to transition over here to Dr. T, who's going to take over with neurocognitive disorders.
If you haven't realized it by now, probably I will say it, you just heard from probably one of the most experts in substance abuse disorders that I've come to know over the years. You can't hear me still. All right, let's go into, I was just praising Aaron. All right, neurocognitive disorders. It used to be a different, in the DSM-4, they used to have separate diagnoses, I guess, vascular dementias, acquired dementias, amnestic disorders, and cognitive disorder, NOS. Those were, the cognitive disorder, NOS, again, this wasn't a psychology thing. This had to do with the DSM-4, is that mild trauma would fall under mild cognitive disorder. They've done away with all that, and there's two main areas. There's major neurocognitive disorder or mild neurocognitive disorder. And any one of those areas that used to be in the DSM-4 can fall under one of those. So you can have a major presentation of it and a mild presentation of it, and we'll talk about the differences in a minute. The assessment of it, the cognitive domain is complex attention. You evaluate for that. Learning and memory, perceptual motor, or social cognition. The major neurocognitive disorder is characterized by a significant decline in individuals' ability to act independently. So these are people who've had a brain injury, a stroke, Alzheimer's, dementia, are no longer to care for themselves. They require an extraordinary effort from the community to get these people to survive on their own. On neuropsychological testing, it's usually characterized by scores that are 2 standard deviations below the mean or more. So, for example, on the Wechsler memory scale, someone would score on auditory memory a score of 70 or below, where average is 85 to 115, etc. Mild neurocognitive disorder, that gets a lot of negative attention because it sounds like we're pathologizing normal decline in memory as we get older. Wait, why am I here? No, okay. I was right out there. But the mild has to do with other people have seen a change in individuals' behavior and ability to perform. They're still able to take care of themselves. They could be slower, a little bit more forgetful, making a little bit more wrong decisions, but not earth-shattering. Their difficulty in understanding, having to have them repeat often, not because of hearing, because they're having a hard time understanding your vocabulary, or difficulty expressing themselves. Yes, sir?
So the question is, how do you differentiate that mild form from typical age-related cognitive?
That is good. Okay. And one of the things they do is that other people, and again, it's referenced through other people's perspective and neuropsych testing. Other people are saying that it's a significantly different more than what you would reasonably expect from someone that age.
But if it's a family member, they may not have a valid reference for what would typically be expected.
And if the family member that there has been a change, and maybe we should look into it, then you go to the next step, which would be a neuropsych evaluation.
So one last question. Do those take into account age?
They take into account, of course. Yeah, we do that. Yeah, yes. In fact, the norms on the test take age in effect too, as well, and education level. So I won't get into specific neuropsych testing, but it is referenced by age and education level in doing that. So, and on the mild, it's usually 1 to 1.5 standard deviations below the mean on the neuropsych testing as well. And that's why it's important to have those testing done. the DSM-5 has done a very nice job now of saying what are the etiologies of neurocognitive disorders. And this is a list, it's not exhaustive list, but it's the most common reasons for neurocognitive disorders, and it goes, all the way from Pick's disease, head injury, Parkinson's, HIV, etc. Although HIV is becoming much less common. I'm seeing less and less of those evaluations. HIV dementias, much less. So our society has progressed with that. And when you code a cognitive disorder, you usually code as to the etiology of it. So nothing happens in a vacuum in a DSM-5. Especially under neurocognitive disorders. All right, we're going to go into personality disorders, and I know a lot of you have asked me about downloads and resources, so I'm going to go through this a little bit quick, because not a lot has changed here. Personality disorders, there's still 10 personality disorders, but this is under attack. It was lucky that this found its way in the DSM-5. As Aaron alluded to, there's significant progress and changes in what how we assess and what are we labeling as a personality disorder. And there's a very nice alternative model called the hybrid dimensional categorical model, which is taking the old way of doing the assessment and using a trait factor theory of diagnosing personality disorders, and it's being condensed to 6 disorders as opposed to the 10 as well, as we talked about. So let's go on to this. All right, paraphilic disorders. This gentleman brought up a good point. Why wasn't this brought up, gender dysphoria? I just realized why, and I think Aaron talked about it. In the DSM-4, it was all lumped together because it related sex somehow. I think what they're trying to do here is show that this is far away from gender disorder as you can get, that there's not a relationship. They're independent. So that's my theory, Aaron. What do you think?
The idea was basically we were putting everything in one chapter that even made anybody think about sex. But gender identity has nothing to do with sex. Sex is a part of maybe what can be impacted by it, obviously. But it's not a sex disorder of some kind. So it made sense to them to separate sexual dysfunctions, paraphilic disorders, and gender dysphoria into separate chapters.
And this is way down the line to once again to show the independence of this disorder versus the others. And when I've read the DSM-5, sex never came to my mind. No.
Also, when you look at the developmental stages, paraphilic disorders,
Just kidding.
they're saying paraphilic disorders are more likely to occur into the adult part of the lifespan.
Yes.
Gender dysphoria may have a slightly earlier onset on average because they're going by lifespan when they organize the chapter.
Good explanation. All right. So paraphilic disorders. I guess the short of it is you can think whatever you want as long as it's not creating stress in your life or hurting someone else. It's not a disorder. End of the line. End of story. It only becomes a disorder if you meet the second part where you're
entitled to your paraphilias.
You are entitled to them. Enjoy away. But if it creates stress and causes you significant problems or someone else, then it's got to be dealt with. Then it's a problem in doing that. 2 broad areas. There's the courtship, which is voyeuristic, exhibitionistic, futuristic, and algolagnic, which are the pain paraphilias, sadism and masosadism. That hasn't changed. It's just showing us that it was just brought over. Medication-induced movement disorders and other adverse effects of medication, that hasn't changed either. That's still very much part of the DSM-5 picture as well. And these are some of the more frequently occurring ones due to medication. And they're serious. These are serious side effects doing that. The tardive dyskinesia one, that has become less and less as the new antipsychotics have improved and being a lot more specific and avoiding the extrapyramidal synapses, or those are the synapses that has to do with motor movement, and doing that. All right, emerging measures and models. Assessment measures. There's a new way of diagnosing, and they've done a much better job. And they've kind of taken a cue from physicians. What they've done now is cross-cutting symptoms measures, levels 1 and 2. So there are about 13 broad areas on an interview section, and we have the interview book up here if you want to take a look at it, where you ask 1 or 2 pertinent questions that flag a possible disorder in one of those 13 areas. So, for example, in depression, does suicide, or you ever, for example, does suicide ever come to your mind? If someone says yes, then you go to the next set, level 2, which expands upon that possible, looks at the diagnosis in further depth. So theoretically, you can do an evaluation or a clinical evaluation within 20 to 30 minutes to get a pretty good idea of what the diagnosis is going to look at or where you're heading. And with some of the apps that Aaron will talk about, you can take a look at the DSM-5 while you're right on your iPhone and working with this cross-cutting symptoms. So anyway, it goes through different areas of the DSM-5 very quickly. The next area is what's changed is the World Health Organization Disability Assessment Schedule 2.0. As Aaron mentioned, we've done away with the GAF score, the Global Assessment of Functioning. This is a recommended alternative. I use it most of the time to replace the GAF. It takes longer, but I like it better because it takes a look at 6 areas of functioning of an individual, and you get to rate it as mild, moderate, severe. And the 6 areas are like mobility, communication, getting along with others, participating in the community, and then you get a separate measure in those different areas and an overall one. Obviously, it lends itself very nicely to treatment, especially for those of you who have to develop treatment plans in vocational settings or therapeutic settings. The cultural formulation interview, there's a whole section on how to interview for culturally sensitive issues that look and appear like possible disorders, which are really more culturally driven than a disorder, and they've included that, just a sensitivity to that as well. Conditions for further study. In this area, my guess is maybe 1 or 2 might make it into the DSM-5 just like the other ones, or may stay conditions for further study for another 2 or 3 revisions. But some of the ones I want to point out is the one that's under neurobehavioral disorder associated with prenatal alcohol exposure. That looks and sounds like fetal alcohol syndrome, but the defining difference is that it has to be IQ 70 and under. So that may find its way in there. Another one that might come back is the persistent complex bereavement disorder. I guess when they took away bereavement, when they added bereavement as a possible diagnosis under depression, and when they took that away, now they're coming back with this one that, okay, well, maybe bereavement can be a disorder if it's persistent and in spite of, and it doesn't go into the criteria of full-blown depression, there's never been a history of depression, but they're constantly bereaving this individual, then that may find its way in as well. All right. Let me turn this over to Aaron, because this is a great section on how to get more information on what we talked about.
Okay, so this is probably the part that a lot of you have been waiting for, is how do I get stuff? I'm going to show you how you can get stuff that you pay for, and I'm going to show you how you can get free stuff. Especially if you're a student, free stuff comes in pretty handy. So starting with stuff you can pay for, I've got stuff that people can pay for here. For example, Obviously, you've got your DSM-5. There is no substitute for the full DSM-5. There's no other way to get it but to buy it and pay for it. It's kind of expensive. Anybody bought it recently? I think it's around $150 now or so. Is that right? Or huh? 110. Oh, has it gone down? Oh, I wish it went down before I got it. Okay, so there's that. This is the diagnostic exam. This is a sort of a guide that kind of shows you how you can sort of quickly assess and evaluate by implementing the new diagnostic criteria. This thin little thing is probably like $69. Similarly, this is just the diagnostic criteria. So what it does not contain, the desk reference, the desk reference to the diagnostic criteria from DSM-5 is what's called. What it does not contain is all the statistical background, the prevalence, how the disorder unfolds over time, special considerations, all those resources that are in the appendix, all that stuff. It just gives you just the diagnostic criteria for each disorder. It is very, very useful, obviously. But this thing, which reminds me of a little New Testament Bible, is $69. Exactly. So they do you're paying not just for the printing of the material, but all of the panels and everything that went into creating all this. Yes?
I just want to say that's a great tool to study for the exam. And take it to bed at night, just that has all the information.
Yeah. And I've got an even better tool that I'll show you in just a second. So, I'll also show you, we talked about these assessment measures. Those are free. You can download them from dsm5.org. This link, you click on it. Oh man, it's going to use Internet Explorer. It's going to take forever. Okay. So, this is the DSM-5 website. On the right-hand side, you'll see some free stuff. Man, not even the scroller doesn't even work. Okay. This, by the way, is a pretty cool resource. Highlights of changes from DSM-4 TR to DSM-5. That's free. It's like 20 pages long. It walks through everything that's changed with the diagnostic criteria. So that's a good download. There are specific flyers for specific disorders going over the changes. But I want to really draw your attention to a link that says online assessment measures, which I cannot find. There it is. I saw it a second ago. Online assessment measures. Big, big helpful link. If you click on that, you can download we talked about those two different levels, cross-cutting symptom measures. The idea there is that you don't necessarily evaluate by asking every question about every disorder in the DSM. Realistically, you can't do that with your time constraints usually. What you do is you ask a small number of questions that screen for whether there could be a hit in any of these other disorders. That's level 1, that small number of questions. If you click on level 1 cross-cutting symptom measure, it gives you a version for adults, a version for kids. If you click on the adult one, I'm going to show you this. It's a PDF form. And it picks like a small, I think like 20 questions or something. You got to get past the disclaimer page. It's really a one-page tool, a screening tool that you can administer or give to clients in your lobby or whatever. It's very quick for them to fill out. They just circle. It asks, in the past 2 weeks, have you had to deal with this stuff? And then it asks 23 questions. Each of these Roman numerals corresponds with a category of disorders. If you get a hit, then you know that you need to move on to level 2 for that particular category of disorders. This is all explained on the final page here. So, for example, if you get hit on the 2 questions that are highly predictive of a depressive disorder, then you know you need to grab a level 2 depression tool. Like I think they have on here something like the Hamilton-Diston, maybe, or something like that, and then you'd administer that to get an even clearer picture of their symptoms with that disorder. So it's a pretty handy-dandy tool, and it's time efficient. Another cool thing that you'll see is the cultural formulation interview. Again, they really want to be culturally sensitive with the DSM-5. I really like that interview. If I was meeting with somebody, I'm like, I'm not really sure exactly what could be the cultural influences here that might be impacting their symptom presentation. I might administer a tool like this. Some examples of some of the questions are things like, what do your neighbors, family, and friends in your community say about this problem? Would be an example of it. Or what do your faith leaders in your community say about this problem? Yes? That's called the Cultural Formulation Interview. And again, if you click on that online assessment measures page, right here you will see Cultural Formulation Interviews, and you click on that, and it gives you those tools. The WHODES, you can download that for free by clicking on Disability Measures. So that's the optional replacement to the GAF score. Free. So that's pretty cool. I won't show you it because we won't really have time. So here's the next resource I want to give you for free stuff. If you go to my website, which is anorton.com, and you click on resources, then there will be DSM-5 resource page for counselors and counseling students. And if you click on that, I just messed it up. There we go. The first link you will see is a PDF version of the presentation today, DSM-5 update for counselors and counseling students. So that's how you get your PDF of today's slideshow. But if you go down a little bit further, you'll also see I have a link to the online assessment measures DSM-5 page. Some information about the app, which I'll show you in a second. This is a free PDF tool that I created to help people screen for substance use disorders. It gives you a checklist of the 11 symptoms. So that's available on that site.
Yeah, like they use it and download it.
Yeah, if it's on my website, you can download it and use it. Yes, it's yours. Merry after Christmas. So we've got these two YouTube videos that are also on there of people who haven't yet figured out that they're not allowed to be posting these slides on YouTube. So one of them is a professor, I can't remember where he was from, but Dr. Jeffrey Nevid. He's got a little update webinar that he gave to faculty and students. This one is a more lengthy presentation from the Emory University School of Medicine, a YouTube presentation. They're not exactly the most exciting things, but they get their job done of giving you some information, and they're free, unless they've been taken down already. But so then I'm going to very quickly show you. This one is not a freebie, but I'm going to show it to you anyway. Oh, I got to go all the way to the end here now again. The app. If you have an iPhone or an iPad, I don't know if Android devices have this as well, but you can download an app. It has all the diagnostic criteria, just like the little New Testament DSM-5 over there has. Same thing. But what's different is that you get on the left-hand category here, you get all of your categories are there, so you can click on one of those 22 chapters if you want. Or you can just type a keyword. It doesn't show it on this because I didn't give you a very good screenshot for that. But there's search right up there at the top. You can type in any word and it'll bring up the diagnosis for you. Just click on it. Very quick and easy then to get to what you're looking for if you don't have the 22 chapters and their orders figured out in your head. And then when you click on the disorder, the chapter, it gives you an introduction to that category of disorders, and then you can click on a specific disorder. Like, I think what I'd done was clicked on alcohol-related disorders, and then it gives you all the different alcohol-related disorders. You click on any one of them, and all the diagnostic criteria are there. The one thing that it has that the Pocket DSM-5 desk reference doesn't have, which costs the same amount, they're both $69, unfortunately. The most expensive app you'll ever buy. If you have both an iPhone and an iPad, by the way, then it works on both. You don't have to buy it twice. It'll transmit and it's forever yours. Whatever Apple device you ever get will play it. I'm hoping that when they update the DSM-5, the updates will be free to the app, but don't take my word for it. There are those who are much more cynical than me about that. So, But what it does have, the DSM-5 desk reference doesn't have, is videos. In each of the chapters, somebody from that panel or the chair of that panel will talk about why they made the changes that they made and give you a little bit of verbal information. They're not long videos and they're not particularly impressive, but it gives you a little bit of stuff that you don't get in the regular desk reference. And if we go back to resources, another resource that unfortunately you would have to pay for is next month, and there's a typo there, it's February 7th and February 8th, is the 2-day state annual conference for the Florida Mental Health Counselors Association. Anyone already registered to go for that? Okay, actually there's a decent number of you. Well, there are, by my count, 9 hours of DSM-5 training available, including, I'm going to be doing a 3-hour workshop on using the DSM-5 revisions to substance use disorders and the new 3rd edition of the ASAM treatment criteria, which just came out in October, I think. I'm going to take both of those, go over all the changes, and I'm going to show you how you can now implement this for conducting quality substance abuse evaluations in your practice or your agency. So that stuff is available at the conference. And there's they're going to be doing a highlight on the mood disorders. They're going to be doing how can you refine your assessment skills using the DSM-5, some of those things. And I think that covers it for resources. So, wow, we are right on time. Any questions?
Ding, ding, ding.
Yes.
You mentioned you were going to have something specific for the exam.
Oh, yeah. When somebody was mentioning that the DSM-5 desk criteria, or the desk, what's it called? The desk reference. That's a good resource to use to study. I'm saying in addition to that, there's an app that has all the same information that might make it, even more, for some people might even prefer that over the book.